Good morning, everyone. And today our topic of discussion is scleroderma. Now, scleroderma, um, this condition is also called as systemic sclerosis. So, scleroderma or systemic sclerosis, and some of the time it is also called as systemic scleroderma. They are all the name of one condition. So, I write over here scleroderma, but when I'm writing, starting from here, I'm writing systemic sclerosis because both are the name of same condition. Now, what is scleroderma? So by definition, it's a non-inflammatory autoimmune disorder characterized by widespread vasculopathy. Okay, so there is vasculopathy, widespread production of autoantibodies, and fibroblast dysfunction causing fibrosis. Now, okay, now first of all, this is not a clinical definition, right? Because whatever is written over here, widespread vasculopathy is something, uh, a pathological term. What are the things which occurs clinically is not, we are not sure, like by this definition. Production of autoantibodies again can be seen on testing, and fibroblast dysfunction causing fibrosis. So this is, you can say, this is not a clinical definition. Okay, so if I will talk more about the clinical definition of systemic sclerosis, it will be like it's a generalized disorder of connective tissue which affects the skin, the internal organs, and the vessels. Okay, so now this one sounds more clinical. So basically, what happens in systemic sclerosis? Um, it is characterized by sclerodactyly or sclerodactyly, right? Now, one thing, it is characterized by sclerodactyly. Now remember, whenever there is sclero anywhere, it is basically fibrosis, right? So sclerodactyly, it is characterized by sclerodactyly with Raynaud's phenomena. Now, Raynaud's phenomena, I think all of us, you know what is Raynaud phenomena, right? So Raynaud's phenomena, or you can say digital, like the digits, fingers or toes, ischemia. So this is like, you know, how clinically it looks like. Okay. Now, the important thing about this condition, systemic sclerosis, it most of the time it occurs in adults, in fourth and fifth decades of their life. And previously, they call, like they divide or they classify scleroderma into two categories. One is called as okay. Previously, see, you can see scleroderma or systemic sclerosis is classified into localized or generalized, right? So basically, previously they call it as generalized, they call it as diffuse systemic sclerosis. Okay, so you can see like the generalized now is classified into two main things. One is diffuse systemic sclerosis, and one is limited systemic sclerosis, right? So now Basically, the limited systemic sclerosis is also called as CREST syndrome, CREST. Now, what is CREST, CREST syndrome? You can see over here. CREST syndrome, how its name is CREST is because C is for calcinosis, R is for Raynaud's phenomena, E is for esophageal dysfunction, S is for sclerodactyly, and T is for telangiectasia. Of course, like I'm going to show you now how sclerodactyly looks like. But before talking about the pathophysiology and all those things. So, scleroderma or systemic sclerosis can be localized and can be generalized. Now, when it is localized, so there is no involvement of internal organs. Okay. And it is mostly children and young adults which get this kind. And it is very, you can say it is just limited to the skin. For example, morphea or linear localized scleroderma. Now, what is morphea? Because I did not include any of thing, in the slide, but I'm going to show you. For example, you can see all these photographs. So see, for example, this photograph, they have the involvement of this part of the skin, right? So this patient who have morphea, basically all the internal organs are normal. Or you can see it is a very localized type, right? Just in this region. Or very localized type, for example, here, right? So it could be, this is called as morphea. Or I will show you linear localized scleroderma. Simply, it is see, like this one. Just this linear patch of the skin is involved, or you can say, see, just linear patch of the skin is involved, right? So basically, this is how this localized form, and remember in localized form, there is no involvement of internal organs. Whereas in generalized, which is divided into limited and diffuse, you can see the limited one. There is skin sclerosis restricted to hands, face, and neck. Okay, that's what is called as limited. It occurs in third to fourth decade, and pulmonary hypertension is common. Or CREST syndrome can be there. Okay, C is for calcinosis, R is for Raynaud's phenomena, E is for esophageal dysmotility, S is for sclerodactyly, and T is for telangiectasia. And the other one is diffuse systemic sclerosis, like in which there is widespread skin disease proximal to wrist. Okay, like wrist, and if you will come towards the medial side, can involve trunk, tendons, and there is early visceral involvement like renal or pulmonary fibrosis. Now, guys, what is the pathophysiology of this condition is poorly understood. We don't know what is the thing which causes this one. But what they know about this condition is like they found a lot of things. For example, exposure to silica dust, vinyl chloride, and things like this. And they found like some of the genetic makeup. Like there is a few evidence of that. Like some HLA types are more associated with this and like this, right? But exactly what is the thing, how it is caused, the thing is not known, right? But of course, there is some immunological dysfunction, like uh, the fibroblast activation, which causes fibrosis, and there is thickening of the skin, okay, and the arterioles become narrowed. Simply, all these evidences are there, but exactly what causes this thing is not known. So this is the classification of scleroderma. Now, what is sclerodactyly? see, their skin looks plastic-like because this one is thick and tight. And what happened is basically there is non-pitting edema of fingers and flexor tendon. See. So see, the skin is look like very plastic tight skin, and there is no creases in the skin. You can see the skin appears shiny. Okay, all these things are there. So this is how they look like. And also what happens, um, the skin of the face, it also become like this, if you will see over here. See, okay. So these are some manifestation of the, see, you can have a look at the feet. You can have a look at the finger. Now this is Raynaud's phenomena, right? And it can lead to gangrene as well. So when you see them closely, what you found basically, they have mask-like faces with tight lips and beaked nose. Beak, see, like, because the nose become very much pointed. Okay, and what we see in basically there is furrows, radial furrows. You can see like this one, this one, this one, this one, around the mouth. Okay, and also what happened, like they have calcinosis, so we can found the calcium deposits over here. Okay, I will show you the calcium deposits over, and with ulceration, you can see the ulceration over here, over here. Okay, so all these are the features of what, this systemic sclerosis. So they have puffy fingers. See, this is Raynaud phenomena. You can see the whitest skin over here. You see, these one are the digital ulcers and scars. Okay, so these are all the features of systemic sclerosis. Now, what I am talking about, I am just talking about the features of the skin. But of course, like Raynaud's phenomena is the vascular phenomena. Now, a very common type of involvement is what, like, they present with dysphagia. Why? Because they have esophageal hypomotility. Esophageal dysfunction, acid reflux, and decrease in motility of esophagus, right? So they basically present with ulceration, strictures, or GERD. Their small bowel, large bowel, all of them, they're affected. Like they have decreased growth, like decreased movements, right? So this thing. Now, the important thing here is what you can say is the pulmonary involvement, right? So pulmonary involvement is very important, and because it is the most common cause or the major cause, you can say, of mortality in these patients. Basically, these patients, they develop pulmonary hypertension. Okay. Now, pulmonary hypertension, as we know, whenever there is pulmonary hypertension, there was we call cor pulmonale, and the patients, they can die very quickly, or you can say within few months. But this involvement or pulmonary involvement is more common in which one? Limited systemic sclerosis. Okay. 6 times more common than the diffuse one. So they present with all the features of interstitial lung diseases, dyspnea, right-sided failure, and things like this. So this is how they have fibrosis of the lungs, they develop pulmonary hypertension, and all these things. One of the thing is renal involvement. Whenever they had their kidneys get involved, they have proteinuria, creatinine become elevated, they present with hypertension. Uh, Few of these patients, they can develop a thing called as scleroderma renal crisis. Okay, so basically what happened, like these are the patients who have malignant hypertension with oliguria. Okay, so and rest, like they can involve, like some of the patients, they get their heart involved as well. Joints involvement is also there, and there is some association with hypothyroidism as well. But these are, you can say, the important things what I told you. So see, basically there is dermatological manifestations, there are GIT manifestation, there is vascular manifestations, there is pulmonary manifestations, there is renal manifestations. Okay, and also I told you CNS can be involved, as well as, you can say, joints can be involved, right? So uh, they have like number of signs and symptoms. So whenever like they have scleroderma renal crisis, okay, what we can also say like hypertensive renal crisis, these are the patients who present with right renal failure and hypertension. Okay, so basically what is going on in these patients is there is fibrosis going on with vasculopathy. Now, as we know, most of these conditions, which are on the peripheries, they are more common in females. I told you in the first lecture. Basically, male to female ratio in these patients is around 4:1. And mostly, I told you, most of them, they are the adults one who get the generalized type. So mostly in, like, it is after the fourth decade, or you can say the fifth decade and the sixth decade. And in the pathophysiology, there is some evidence, like the patients, the people who are HLA, who carry HLA-DR1, they are more commonly involved. And as I told you, they found some of the evidence like exposure to the silica or aromatic hydrocarbons. They are also uh, involved. Now, um, the good thing is, whenever there is limited systemic sclerosis, they have a higher, you can say, survival prognosis. Whereas in diffuse systemic sclerosis, the survival time is is less than the limited one. So what happened is, like anyone who have scleroderma, and remember, like in vascular one, Raynaud's phenomena is common, right? Raynaud phenomena. You can say scleroderma is the most common cause of secondary Raynaud phenomena. Now, if you know like what is Raynaud phenomena, I told you, and show you this one. For example, this is a photograph of Raynaud phenomena. You can see, or this one. Okay. So Raynaud phenomena, like it can occur in many conditions. Like it can occur in different connective tissue diseases. It can be as a result of cold. Okay. Sometimes arterial problems like atherosclerosis and all this stuff. But scleroderma is the most common cause of secondary Raynaud's phenomena. So now, how we diagnose these patients, how the diagnosis is done of this patient. To talk about the diagnosis, guys, this is a scoring system I want to show you, um, which is defined by what you can say, American College of Rheumatology, ACR. And you can see score of 9 or greater than 9 is sufficient to classify a patient as having definite scleroderma. So you can see what are the items: skin thickening of fingers of both hand extending proximal to MCP. It is a sufficient criteria. So see, how much is there? 9. So anyone who have this thing, So we need equal to or more than 9. So the thing is quite obvious that the patient has scleroderma. Other thing is, skin thickening of the fingers, puffy fingers 2, sclerodactyly 4, then fingertip lesions like digital ulcers or scars 2 and 3, telangiectasias 2, abnormal nail fold capillaries. Yes, this is important. What is abnormal nail fold capillaries? What they do, by the way, uh, they put a oil, uh, and they see the nail bed or the nails bed, under the ophthalmoscope or a microscope. Okay, and what they found, like when they have dilatation of the capillaries under the nail bed, that is basically abnormal nail fold capillaries. 2, pulmonary arterial hypertension with or without interstitial lung disease. So maximum we can give 2 score, like either it is ILD 2 or pulmonary arterial hypertension for 2. Raynaud's phenomena get 3, and now the antibodies, which are, you can say, related to scleroderma: anti-centromere or anti-topoisomerase 1 or anti-RNA polymerase 3, right? So you can see, like, this is a diagnostic chart which we can see. So how the diagnosis is done? First of all, clinical examination, right? Clinical examination. So scleroderma is basically a clinical diagnosis, because if you will see over here, 9 is for this one. So scleroderma is a clinical diagnosis, you can say, right? So clinical examination can make the diagnosis. Okay, but of course there are some points for the labs as well. So we can do multiple investigations. For example, what you can do is, like, you can go for CBC, you can go for ESR, which is mostly raised in these patients. Now there is renal involvement, you will go for creatinine, and blood urea nitrogen. Okay. Now the antibodies, topoisomerase 1, anti-SCL 70. Okay. So this antibody is basically specific for diffuse systemic sclerosis. Okay, and anti-centromere is basically present in CREST syndrome, or you can say the limited, what you can say, systemic sclerosis. Very easy to remember, guys. C, remember from C. C for CREST, C for centromere. And the other one is the specific one for diffuse. Okay. Now, there is pulmonary hypertension, so you can do investigations for that. Or, for example, there is interstitial lung disease, so you can do pulmonary function test. Okay, for ILD, interstitial lung diseases. So this thing we can do, or we can do for chest X-ray. We can go for a CT scan of the chest to check for the lungs, and echocardiography as well, because there is heart involvement as well as, you can say, there is pulmonary hypertension, right? So this is like how we diagnose these patients of systemic sclerosis, right? So guys, very easy. If you can remember, like, how the disease present and all this one, and the features are very easy to remember, digital ulcer, calcinosis, all this stuff. Treatment. Now the treatment is multiple, because the problems are multiple. So of course, like, the treatment will be too much. So we have to address many things. For example, you have to manage the skin, you have to manage the vascular problems, okay, you have to manage the GIT, you have to manage the kidney or the renal system, you have to manage the pulmonary problem, you have to manage the cardiac abnormalities, right? As well as there could be joint involvement, so you have to take care of the musculoskeletal system. So the management is quite long by, because there are many things, which arises in these patients. So what happens is like of course, like we manage all these conditions. For example, we have to manage hypertension, you have to manage esophageal reflux, you have to manage Raynaud's syndrome, and all these things. So what can be done? For example, anyone who have skin involvement, and there could be ulcers and all this stuff. So skin hygiene is the key. Okay, and what we can do, we can put them on steroids, prednisolone, and also other immune modulating drugs like methotrexate. But mostly, like steroids are given for these patients. Okay, vascular Raynaud's phenomena. So first of all, we educate the patient. We tell them to avoid cold, because like the Raynaud phenomena, it comes on exposure to the cold. Second thing, we ask them to quit smoking. Very, very important thing. Third thing, we put them on vasodilators. Okay, so what kind of vasodilators? You can give them calcium channel blockers, and there are many local creams are also available, like local nitroglycerin cream can be given. You can give them prostaglandins E2 inhibitors or prostaglandins E5 inhibitors. Okay, so any one of these drugs can be given. CCB, calcium channel blockers, nitroglycerin cream, as well as PGE2 or PGE5 inhibitors. Okay, so simply to manage the Raynaud's phenomena. Now in GIT, if you know how we manage GERD, gastroesophageal reflux disease, so PPIs are the first line. Okay, like omeprazole and all this one, or you can put them on ranitidine, famotidine, all these drugs. And of course, like their GIT motility is reduced all over, like in the esophagus, in the small intestine, in the large intestine. So there is bacterial overgrowth. So we can give antibiotics for bacterial overgrowth, right? So this can be done. Renal disease, ACE inhibitors are the best one for this one. Pulmonary disease, if there is interstitial disease, consider giving them cyclophosphamide. Okay, but if anyone have pulmonary hypertension, then you all know what is the treatment of pulmonary hypertension. Basically, we cannot do much, but of course, we give them, like when we discuss pulmonary hypertension, we give them bosentan or PDE5 inhibitors and other drugs as well. So simply refer to the treatment of pulmonary hypertension. Cardiac involvement, like mostly it can cause pericarditis, so we can give them steroids for that. Like we can put them on steroids. Musculoskeletal system, they present with joint pains and things like this. So arthralgias, arthritis, or myositis. So we can give them NSAIDs as well as steroids. Okay, so the prognosis of this condition is, you can say, more than 70% of the people, they survive for 10 years. So like the prognosis is not so bad. Like they have quite good life, but of course, like anyone who will develop like the renal crisis or things like this, of course the condition become bad, and of course we have to treat them, to treat these things, right? So this is how the condition behaves, right? And okay, so I think like that's all about what you can say systemic sclerosis. And remember about um, CREST syndrome. um, don't memorize this table. There is no point to remember, but remember the main features which I told you: calcinosis, sclerodactyly, Raynaud's phenomena, digital ulcers, calcium deposits, puffy fingers, nose, beaked nose, and tightened lips and with furrows, right? So this is what you can say. And telangiectasias, okay? So all these features should be remembered. So that's all, guys, for systemic sclerosis. I hope you understand, and I will see you in the next lecture.